All right, hi everyone. We'll be getting started shortly. Thank you all for being here today. We're just waiting for a few more people to come in. We're about half of our expected attendance right now, so we might wait a few minutes. But as you can see here, we have our speaker, Dr. Shoham-Hazon, here to explain to us his sort of story in rural ophthalmology. So we'll just wait a few minutes and then we'll get started soon. Okay, so I'm going to turn the waiting room off, and I think people will just come in automatically, so we can get started. So I'd just like to say hello and welcome to the first event of our NorthernVision speaker series. We're happy to be starting this organization with the goals of promoting rural ophthalmology to medical students and residents. The ultimate goal of this group is to promote increased awareness and access to ophthalmology in remote and indigenous communities by improving education around how to serve these populations to aspiring and future ophthalmologists. So for this goal, we're intending to have more speaker series on rural ophthalmology for medical students and residents specifically. We'd also like to let you know that the Zoom call will be recorded and posted on YouTube for people to view at a later date. There were a number of people who are unable to make it due to their sort of medical shifts at the moment. So I'll hand it over to Hamza as well to discuss our survey.
Yeah. Before we introduce our speaker, if you haven't done so already, we had sent an email to everyone that registered about a survey. We'd really appreciate if you could take some time to fill that out, as that will greatly help us to see the impact of sessions like these, and then also to receive feedback. So I will post the link again in the chat. And as we move forward with introducing our speaker, if you could take some time to fill that out, that'd be really great. Thank you, everyone.
So I'll just introduce our speaker. Dr. Shoham-Hazon completed an ophthalmology residency at the Kaplan Medical Center in Rehovot, Israel in January 2010. During his residency, he was appointed chief resident and was awarded 2 awards of excellence: the Outstanding Resident Award for the Kaplan Medical Center and Outstanding Resident Award for the School of Medicine, Hebrew University, and Hadassah, Jerusalem, Israel. Thereafter, Dr. Shoham-Hazon pursued the highly competitive fellowship at the University of Toronto with the world-renowned Dr. Ike Ahmed. This is a 3-year fellowship that included clinical, surgical, and research aspects of glaucoma, advanced anterior segment, or GAASS, and IOL surgery. During his fellowship, Dr. Shoham-Hazon received numerous awards for presentations in international conferences and research grants for numerous research studies. During his career, he has transitioned from practices of different types, ranging from academic practice to independent and private practice. He is currently practicing glaucoma and advanced anterior segment surgery in independent practice in Miramichi, New Brunswick. Dr. Shoham-Hazon has academic affiliations with Dalhousie and Memorial Universities as assistant and clinical assistant professor, respectively. So I'll open the floor to Dr. Shoham-Hazon to begin his presentation.
Okay, thank you. Thank you, Sean and Hamza, for inviting me. And thanks for all participants. I want this to be as possibly informal as we can. So Sean and Hamza, just feel free to raise questions or stop me. And if there's anything in the chat that you want answered as we go along, we'll do that. I want this to be as informative as possible. So as you guys introduced me, I'm an ophthalmologist. I'm fellowship trained in glaucoma and advanced anterior segment from the University of Toronto. And I did want to include a financial disclosure slide, just because despite being kind of a little bit in the boonies in rural ophthalmology and practicing, I do have affiliations with pharma, and it is possible to have affiliations with industry despite being in a rural community. So part of the outline of today, I will speak a little bit about rural medicine, kind of define it. I'll talk about my career and transitions and practice and specialization. It's kind of the pros and cons of working in a rural environment, community impact of my new center, and why choose rural, which will kind of be embedded in the slides as we go. So kind of preparing for this talk, I had to Google. I said, what is rural medicine? What's rural ophthalmology or rural medicine? And we can basically see, of course, Wikipedia has everything. So it's basically rural health, or rural medicine is an interdisciplinary study of health and healthcare delivered in a rural environment. And the concept of rural health incorporates many fields, including geography, midwifery, nursing, sociology, economics, telehealth, and telemedicine, which has become pretty prevalent due to COVID. And there's naturally research into it. So what I didn't know is that there's actually, and you guys doing your rural diligence, I'm sure you're aware that there's a Society of Rural Physicians of Canada. And surprisingly, but not so surprisingly, the current president is a family doctor from New Brunswick. So kind of local New Brunswick pride. And there's a Canadian Journal of rural medicine. So, I mean, I think rural is what this is all about. So I'll tell you a little bit about myself, just so you'll understand kind of where I come from. So I was born and raised in Israel. My dad was a diplomat in the US, so I lived part of my childhood in the United States. I graduated high school in Israel, and as an Israeli citizen, you're obligated to do a three-year Israeli Defense Force service. So I served in the Army and retired now, and in reserves as a captain in the Medical Corps. There, after I did my medical training at the Semmelweis University of Medicine in Budapest, Hungary. Luckily, it was an English program because Hungarian is a super difficult language to master, but I did manage after a year to master the language, and actually kind of tried already to become somewhat academically active, and published my first publication, which was my part of my school diploma dissertation. After 6 years of medical school, I did a year of internship in one of Israel's most busy tertiary care centers in kind of the center of Israel, followed by a 5-year residency in ophthalmology. And in Israel, the ophthalmology residencies, you do a 5 pure years of ophthalmology. And somehow kind of early in my first year grew a liking to glaucoma. Something that helped me learn about rural medicine is part of our residency program. We did outreach clinics in which we saw about 40 to 50 patients per clinic on those days. So as a young resident, to see such a huge amount of patients and pathology is pretty overwhelming. And I remember my first year of residency is when I actually started those outreach clinics. You barely know anything, and you're already thrown into lots of questions about, doctor, what do I have in my eyes? And those of you who know what my practice currently looks like, and I think I have some students that rotated with us in the participants, you know that this is kind of what I do today. So a 40 to 50 patient clinic today in my office isn't all that different from what I did in residency. Even during my residency, I did a fellowship in ocular blood flow at the University of Indiana. So I took a couple of months and did kind of mini fellowship in research, kind of looking into ocular blood flow along with its association with glaucoma. After that, I completed a 3-year fellowship with Ike doing a glaucoma and advanced anterior segment, after which I was recruited to New Brunswick. And the reason I chose New Brunswick is pretty diverse. One reason was that actually New Brunswick did allow an IMG just like myself to be able to practice in Canada with North American training as in my fellowship. And partly because at that time, and actually as well today, there is no glaucoma and advanced anterior segment surgeon in the entire province. So I wanted to go to a place where I could be of use, where I could be of service to the community. So in the past decade or so, I've been in practice in New Brunswick. Then our first child was born. We returned to Israel for a bit of a parental leave, and then back to New Brunswick in 2017. And again, even since then, I am still the only glaucoma and advanced anterior segment surgeon in the province. In the past, patients would usually travel to either Quebec or Nova Scotia to get glaucoma and complex anterior segment care. What happened during the pandemic is all borders of all provinces were closed. So you had to stay within the province in order to get services that could be rendered in the province. So by default, the pandemic helped increase awareness to the service in Miramichi, and we kind of became a tertiary and referral center for glaucoma and advanced anterior segment. Basically, every surgical glaucoma or complex anterior segment were referred to me. And just to put it in perspective, the population of of New Brunswick is around close to 1 million people, 700 to 1 million. And the diversity of the things I did, so I would see kind of dislocated IOLs, secondary to pseudo exfoliation, and we can see kind of the edge of the lens up here, and some pseudo exfoliation flakes in the vitreous. So I'm trained to fix that. Also, this is a patient with rheumatoid arthritis that had an inferior Zen placed, and the Zen eroded due to lack of access to OR. I had to remove the Zen in the slit lamp. So just, you can kind of see it again, just speculum in the eye, lots of iodine, lots of prayers, sterile tweezers, and just removing the Zen, small little noodle and a gush of aqueous comes out. And part of my glaucoma care is doing cyclophotocoagulation. This is a case of micropulse transscleral laser therapy or transscleral CPC, which I do in the office. So these are patients that not necessarily reach the end of the road, but require some glaucoma care. And sometimes either if surgery is inaccessible or too risky, we do perform cyclophotocoagulation in the office. So that's kind of how I do it. It's not a sterile procedure, so I'm not wearing gloves. There's no OR or sterile drape. And you can see this patient already had a tube shunt placed as well. So this is not their first rodeo. And other things that are nice to do in a office setting is various laser procedures. So this is a laser that I purchased at the beginning of COVID, when again, access to the hospital was scarce. And I still needed to do lasers for glaucoma, for retina. And this is just a laser that was mounted and is in one of our lanes in the center. And part of, again, not so much glaucoma and advanced anterior segment, but this is a patient that I was following for glaucoma, and she presented for a routine exam. And on her exam, I basically found an inadvertent retinal tear. She was nearsighted, she was a myope, and yeah, some moving eye and lens here, but you'll see, there we go, there's a retinal tear in the kind of mid-periphery of her retina. And again, having access to laser within my center, within one of our lanes, I just told her, listen, this is the situation. After discussing risk, benefits, and alternative, she actually wanted to have her retina laser that day, and that was, and I said, if this were my eye, that's what I would do, and some wiggling here, but eventually got the laser done. You can see the barrier laser on her retina. And of course, part of being kind of a comprehensive specialist or subspecialist, we do perform routine YAG capsulotomies, as you see on the left, and iridotomies on the right. Again, everything done within the comfort of our own center. So some of the pros and cons of practicing in rural area. So I kind of put them side to side or side by side because they are kind of parallel sometimes. So when we think of the pros, you are it when it comes to ophthalmology, because then perhaps the next ophthalmologist or subspecialist would be maybe 5 hours away. At the same time, it's kind of a con because you're it. So you're the only one that can treat the patient. And some patients have never been across the border to a different province, and they rely on you to do your best to treat them. Another pro is diversity of practice. There's a large scope of practice, ranging, in my case, from glaucoma, cataract, but I do a lot of other things that are medical retina, a lot of lasers that are pertaining to retina, and intravitreal injections. The scope and disease burden of intravitreal injection is increasing, and the need is there. So when I joined the current practice, I was told, you know, you can do intravitreal injections, or you can choose not to. You do whatever fits your scope. And I've been doing intravitreal injections since my residency, since 2006 and 7, when it just broke out and started. So I'm very comfortable with diagnosing and treating patients with different vascular retinal diseases. So I do a fair amount of intravitreal injections. And again, it adds to the diversity, but also the service that you provide to patients. And I wrote also keeping it fresh, because you have to always be up to date. You have to read all the current publications, and you have to go to different conferences. For example, I was just at Sally Letson in Ottawa, and I plan to go to the Atlantic Eye Symposium in Halifax this weekend, and you have to keep up to date with all the subspecialties. Another pro is close contact with community. So of course you need to have good relations with your colleagues, whether they're in Emerge, whether they're in radiology, whether it's just your family doctor that's helping you co-manage a patient. So both professional, but also personal. So you kind of know the patient, but you know their family too. So you're most likely treating the husband and maybe the parents or grandparents. So it's kind of like a community setting. It's kind of like a little commune when you're in a rural setting. And I'll talk about celebrity in just a second. I'll show you a few pictures from the paper, and you kind of become a little bit of a celebrity if you're prominent enough and you feel like you want and you can make a difference. And part of a huge advantage is having a short commute to work in a smaller town. So my office or my center is about 6-minute drive from my house, and the hospital is about 15 minutes. So also traffic is not much of a concept in smaller rural communities. So you know that it will take you 6 minutes. There's no traffic or rush hour. So that's a pretty amazing lifestyle, especially if you come from big cities and you want to settle down in a safer, smaller community. As for some of the disadvantages, so of course, being in a smaller center, there's lack of subs and specialty services. For ophthalmology in particular, we look to collaborate sometimes with neurology, sometimes with neurosurgery, or even ENT. At the current time, we don't have any of these 3 subspecialties in Miramichi. So if we have something that involves, let's say, the sinuses or the brain, and of course, lots of things do, we have to rely on services outside of our region. And this kind of leads to also some challenges with getting patient or access to care, and you do have to pull some strings. You have to sometimes call connections and say, you know what, I have this unique patient. Do you mind taking care of them? And the nice thing about it in New Brunswick is kind of everyone knows everyone. So the community really matters, and we do the best to treat our community and service them. So when I said celebrity, this is kind of what I meant. So the Telegraph Journal is a New Brunswick journal. They have a Miramichi branch, which is the Miramichi Leader. And I've been, in it for several reasons. One of them is the concept of our new center that was featured in the paper. And I have built 2 operating rooms on the 2nd floor of our building. So the same journalists featured the operating rooms and some personal things. So when you live in a small community, of course, personal does matter. So I'm married to my husband, Effie, and we have 2 kids. So when there was Pride prior to COVID, somehow we got our family featured in the paper as well. And I say celebrity, but this is not so much. So since we're civil servants, so to speak, and we get paid by the government, you often, every year, your salary is actually published in the newspaper. So this article stated which doctors billed the most in 2022. And the top 10 most of them are ophthalmologists, and I'm somewhere in there as well. Not to say that we bank everything we bill. So ophthalmologists have the highest overhead of all specialties. So that's kind of like a good and bad thing about being in the limelight. So I'll show you just a couple of kind of videos from the center that I design and build. It's 8,000 square feet ophthalmology center that has our first floor is our office. Basically, we've got about 10 diagnostic lanes and 5 doctor lanes. This is kind of still the setup during COVID, where we had a few chairs in the waiting area. Some of the pictures are up already since then. And we kind of have this waiting area and all our diagnostics, which you're kind of familiar with perhaps from your ophthalmology rotations. This is our waiting area for our patients. And something, again, that's nice in the rural community is you get patients providing their art to you. So the picture that we saw before is actually a patient that drew a picture and gave it to us as a present for our center. That is Dr. Lichtinger, our cornea and advanced anterior segment surgeon. And that's kind of our center in a nutshell. And again, that is our first floor. The 2nd floor is we've got 2 operating rooms, and the 3rd floor is a boardroom and our research center. Again, being in a small rural community doesn't mean that everyone is just a comprehensive ophthalmologist. So we have actually our senior, not so senior ophthalmologist, Dr. Sharma, who is a comprehensive ophthalmologist, but has a keen interest in pediatric and neuro-ophthalmology. So all our kind of head scratcher, all our difficult cases, we consult with him. We have another subspecialist, Dr. Zomer, who's an oculoplastic surgeon. She doesn't work in our center, but she will be doing surgeries in our center. We just saw Dr. Lichtinger, who's a cornea and an advanced anterior segment surgeon, fellowship trained in UFT. Dr. Winter, who's a pediatric and neuro-ophthalmologist, and myself, glaucoma and advanced anterior segment. So again, just thinking of rural ophthalmology in terms of subspecialty. Miramichi in New Brunswick currently runs the heaviest subspecialty service in the province. So kind of what we're looking for, or part of maybe what your mission is and what my mission is in rural ophthalmology, is looking into medical school rotations in rural communities. I know each and every week we have medical students that come and rotate with us. We had a 2-month summer research student from Sherbrooke. We had recently a medical student from Munn. We're going to have more students from Dalhousie. We do perform a lot of research projects still in rural communities. We've got about 12 different research projects going. We have published about 5 peer-reviewed in journals in the past year. Kind of my also vision and hope for the future is to have some residency rotations within rural ophthalmology clinics, again, just to show that rural ophthalmology is as attractive as maybe a large center or a big city. And again, some of what I've started talking to residency program directors is trying to create residency spots dedicated for rural ophthalmology positions. I know for certain that there are a few ophthalmology positions vacant in New Brunswick. I know for a fact that Newfoundland will be losing a lot of its ophthalmologists, some of them to retirement. So there is a lot of place to flourish in those communities. That's it for me. I'm very open to any questions.
All right. Thank you so much, Dr. Shoham-Hazon. I'll open the floor to questions in the chat or via audio or video. Anybody is allowed to turn their mic on and ask a question. And if we don't have any right now, I'll ask one first. Dr. Shoham-Hazon, in a sort of broad sense, how do you think we can improve eye care for rural Canadians? I guess you sort of touched on this a little bit in your talk, but in, I guess, a few steps, what do you think the most important way to do this would be, or the most effective way in a sort of shorter timeline?
So I think, doing outreach clinics is a very good way also for residents to get out there and residents to be able to offer their services and their knowledge to the community. Just like for myself as a resident, we would go to outreach clinics that would hold routine ophthalmology clinics. The patients would assume that they're seeing a specialist. They were not seeing a specialist. They were seeing a resident, but it allowed us to take the special unique cases and actually bring them back to the tertiary care center. So even currently, residents can go and perform outreach clinics, and that will allow some rural communities to benefit from ophthalmology care. I used to actually do a clinic out in Tracadie, so up north, back in my earlier days. So even established ophthalmologists do sometimes go to smaller centers to provide their services. So that's my opinion.
Okay. The other question I have is regarding teleophthalmology. Is there a role for teleophthalmology in your practice, or is there a role for teleophthalmology in rural practice in New Brunswick?
So I think for some communities, it may serve a role. When COVID broke, I started calling patients. Let's not forget that my patient demographics are more of the kind of senior types. Some of them are not as computer savvy as maybe our younger generation. So I found that in my practice, it was a little hard to implement eye exams over teleophthalmology. But I think there is definitely a place in some communities. And as this option grows, I'm sure, just like we find, blood pressure cuffs at Choppers or Costco, I think potentially maybe one day there's going to be like a fundus camera. So you sit in front of a machine, it takes a picture of your eye, it sends it to someone. Plus, artificial intelligence is a very big thing. So a lot of platforms these days offer almost a diagnosis upon just using AI with taking a picture and telling the professional or the technician, patient has diabetes, patient has a risk of glaucoma, and things like that. So I think there's very there's a need. We have to be better at implementing it.
And I'll ask one last question before I hand it off. Do you ever find it challenging to be the sort of comprehensive specialist in New Brunswick? I think you mentioned previously that you are also doing retina procedures. You're also the glaucoma surgeon. You're essentially the master of everything. Is this a challenge for you sometimes?
It sometimes is a challenge because you sometimes see things that you're not, you don't see every day. And you're kind of like scratching your head, what is that? And who's the next specialist I can refer to? And we do have some locums that come and visit our practice, and they're like, oh, I found retinal tear, but it's way out there in the periphery. I can't do it. I'm going to refer it. I'm like, dude, you're not referring to anyone. You are it, right? So you have to do your best. And again, as I said, you're it. So it is sometimes a challenge. You do your best. There's always an alternative. So if you cannot find a diagnosis or a treatment, there's always someone to refer to. But I remember very early in my days here, there was a gentleman that had a huge retinal tear, which kind of was a very scary tear for a detachment. He had started having some fluid around his retina, and we were like, you have to go to Halifax. We're going to have to do something. And he's like, I'm not going anywhere. You're my physician. You're going to do it. And we literally saw him every single day, added a little more laser, a little more laser, a little more laser. And now I've seen him 7 years after. His retina is attached, his laser caught on well, and he's fine. He didn't have any detachment. So it is a challenge in a way. You have to step it up. But there is support. So if you need to call a friend and say, you know what, can you take a look at this picture? I don't know what this is. Or I want to do this. What do you suggest? You have that support. You have that support.
Yeah, I wanted to ask a question as well. Thank you for that presentation, Dr. Shoham-Hazon. As a medical student myself, and I think we have some residents here as well, what sort of tips would you give to us if we wanted to pursue a career in rural practice?
So first of all, I think you have to put yourself out there. I think you have to come and meet with ophthalmologists in the community, or even come to do ER rotations. In our emergency department, there's actually a slit lamp. So if you have an interest in ophthalmology, you can see patients in Emerge. We have Emerge residents. We have medical students that call me from the emergency department and say, you know what, I've seen something on the slit lamp. Can I refer the patient to you? And sometimes, if I'm actually at the hospital, I say, you know what, join me and we'll see the patient together. So putting yourself out there, meeting with, if there's let's say if it is ophthalmology and there's a rural ophthalmologist that is practicing, reach out to him, say, you know what, I'm interested. Can I join you for an elective for a day? Not everyone is capable of hosting another person to tag along, but I think most of us are very keen on being able to teach and share the interesting pathology that we experience in rural ophthalmology that sometimes you don't really see even in the primary and tertiary care centers.
Yeah, thank you for that. I have one more question, and it's surrounding more so like medical technology. In many rural areas, and maybe in your area as well, there might be a lack of some medical equipment. How do you sort of go around that? Do you sort of look for innovative ways to implement things? And if so, how is that done?
So I recognize a few student names here, but I won't pick on them. But we have a lot. So as you said, ophthalmology in particular, we've got a lot of technology that's evolving year by year. And when I built my center, I somehow made sure that I'll have enough rooms to expand. And even though we have expanded, there's always new technology, and I'm always looking for new things. So the best way of acquiring new technology is having it as a trial. So we recently got a fundus camera that kind of does a very nice wide field picture of the back of the eye. And I tried several cameras. I spoke to the pharma companies and I said, or the reps, and I said, can you bring the machine to us for a few weeks? We're going to try it out. And if we like it, we buy it. And I went through just recently 3 cameras, and I knew eventually what I wanted to purchase. As the same for, let's say, optical biometry. So cataract surgery is kind of our bread and butter. Since 2005, we're used to doing intraocular lens calculations based on an automatic optical biometry or calculation. And when I built my practice, there was a specific calculator that I used for many years. I made sure that I purchased that one. My current cornea specialist has a keen interest, obviously, in cornea and corneal pathologies, and he knew that a new machine is coming out. And again, we had a trial. We brought it in, we tried it. It's an amazing machine. And actually, one of the students here is doing a study comparing those optical biometers, and we'll be publishing it because it has not been published, that comparison. So you just have to reach out, try the technology. There is so much technology. So when students come and rotate with us, they're kind of overwhelmed because I said we've got about 10 diagnostic rooms. So patient before he sees us usually goes through at least 2 or 3 or more diagnostic tests. And even some patients come from, different places, and either optometrists or different ophthalmologists. And again, just because we're somewhat subspecialized, we've got maybe more equipment than others. And patients, appreciate that they have the, the best technology and the cutting edge options for them.
Dr. Shoham-Hazon, thank you so much. I have a question for you as well. I was just wondering what your thoughts were. Do you feel that residency rotations in rural locations provide the chance to experience and learn from more unique ophthalmic cases? And do you think that that this should be something that should be mandatory for residency training?
If I say mandatory, I'll get in trouble. So I'm not going to say mandatory, but I think
Fair
it's
enough.
critical. I do think it's important. I mean, we have a few students here that have been rotating with us, and some of them wrote case reports on really unique cases that are really not experienced. And I've been in ophthalmology, so I started my residency in 2005, and since I've been here in New Brunswick, I have seen pathologies that I literally had to not reopen the book, but open the book. And well, not the book anymore. We open the internet, but discover new pathologies that as a resident, you don't get to see in even tertiary care centers. So I think it's important for residents to be able to experience that. I think you've got some electives or externships that you can do during your residency, and I'll kind of go out on a limb here and say, if you have vacation time and you want to use that, even just a day or two to experience what rural ophthalmology is, it's going to be worth your time.
Thank you so much.
Dr. Shoham-Hazon, I'm curious, is there a specific pathology that you see more often in New Brunswick or Miramichi that you probably wouldn't see elsewhere?
I can't say something specific. I mean, we've got, so it's a retirement community. So of course we see a lot of AMD. Some of our cataracts are not unique, but I guess by the time they reach us, they're kind of, we call them a Miramichi cataract. They're like a very nice, decent, dense cataract. Up in the Acadian Peninsula, there's a tendency for kind of shorter axial length eyes. So microphthalmia or nanophthalmia is more prevalent here. So we do see a little more angle closure, but also these eyes are not the funnest to operate on. So you have to have a little bit of extra expertise when approaching these eyes with some respect, because not every cataract is just a cataract. So that's kind of what we see. Diabetic retinopathy, I think everyone sees everywhere. So that's a common one.
Okay, so I'll just open the floor again. Any more questions from the audience here?
Can I pick on two?
Yes, if they're okay with it, sure.
I think they're going to log off soon. So I'm gonna ask Sunil if he's here.
I think he is.
I see his name.
Hey, Dr. Shoham, thanks so much
How
for
are
the
you?
talk. That was excellent. Good, thanks.
How are you? Wonderful. So Sunil is a student, is a medical student that's been doing a lot of research with us and rotated with us. I'm going to ask you and Yanis the same question. So what did you find that works in our office, and what kind of drew you? Because you're coming from Halifax, so you're coming from a big city, a big center. What did you find that kind of was attractive for you in, I'm not going to say Miramichi, but in our center?
Yeah, so I think just like you were saying, like the appeal of rural medicine that you get in Miramichi, even though Halifax isn't a huge city, you certainly don't get to see the same breadth you would in a rural community. And also, as you were saying, like the advances in technology, particularly at that center, are just like leaps and bounds ahead. So I'm really looking forward to exploring more of that.
And I'm going to pimp Yanis now. He's going to kill me.
Hi,
Yanis, do you want to
Shoham.
say, how are you?
Good, and you?
Wonderful. What did you like about your experience with us?
Well, I was very happy to be exposed. I got a lot of exposure with you guys, and I passed 2 months with you, and being able to, even to talk to the anesthesiologist and see other surgeries when I was at the hospital, and being able to see the patient and have some time with the patient and take time to discover the patient before you guys come. I was very lucky to see everything. For sure, I didn't start my externship yet, but for sure I'm ready for it, and it was a very great experience.
Wonderful. So just like both Yanis and Sunil said, there's a close communication and connection, both with the patient, the community, but also your other, fellow colleagues, because it's a small town and you have to help each other. And we're there for the community. So that's what it's all about.
And then I have a last question. Est-ce qu'il y a une grande communauté francophone à Miramichi? Parlez-vous français?
I'm poor at it, but I understand. We have a lot of patients coming from the Acadian Peninsula. Okay. So there is a fair amount of French-speaking patients. That is partly why some of our staff are bilingual. For example, today was a huge injection day, and we had a new staff member that is trilingual actually, and she said, wow, I didn't imagine that there were so many French people coming to Miramichi. So that's a definite advantage and my relative disadvantage. I understand fairly okay, but I'm not confident consenting a patient to surgery in French.
I'm sure that's more than okay, and just your contributions to the community are probably more than enough already. So I guess if there are any more questions from the audience, I'll ask one last time. And if not, I will just like to say thank you to Dr. Shoham-Hazon for taking the time out of his busy schedule to be here with us today. I'd also like to thank the members of the NorthernVision team for their excellent work in making this happen.
Yeah, we really appreciate it. And just another note, we also do have a post survey for this event. I will be posting the link, or Sean will post the link in the chat. If you could also fill that out again, it helps us to see the impact of these sessions, and also it's great for us to receive feedback. Thank you so much.
And one last thing to the members in the audience here is that we will be emailing you with information about our upcoming talks, also on the topics of rural and indigenous ophthalmology. Thank you, everyone, and have a great night. Thank you for joining us tonight.
Thanks, everyone.